Okay, uterine disorders. Okay? Pelvic inflammatory disease. This is only due to a sexually transmitted disease. Okay? Pelvic inflammatory disease, or better known as PID, okay, is an infection that originates from the cervix and ascends into the uterus and fallopian tubes and causes mayhem up there. So let me draw my wonderful picture here. You notice that when I draw this picture that it kind of resembles the Dodge Ram. All right, maybe that's where they get the Dodge Ram from. But anyway, you have this, and what's happening here is that there is some kind of infection that happens around here, in the vagina or the cervix, and this could be chlamydia or gonorrhea that are notorious for causing this disease. And what happens here is that if it's not treated, to move up. Remember, this is all connected, so to move up, go gonorrhea. To move up. Remember, this is all connected, so to move up, go through the fallopian tubes, kind of set camp onto the ovary, but can move out over here and cause mayhem on the fallopian tubes, on the uterus, and all around here. And they can cause, what I showed you before, adhesion, scarring. And I kind of showed you that when I talked about endometriosis. The scarring can also cause this, right? It could, if there's going to be some infection that's happened up there, and now this fallopian tube is going to be glued to that like an adhesion, then what will happen is it's being pulled up there, and now the small sperm can't get through this little opening, and we can't have like the egg go through there. So PID can cause infertility because the egg and the sperm can't meet up, can't unite. Okay, and that's our biggest concern, one of our biggest concerns. But also, it could be, if this adhesion is gluing, let's say, the uterus to the back of the abdominal wall, then that could be pulling the uterus, and that could also be causing a lot of pain. Again, you have your intestines all around here. It can glue against the intestines, cause constipation. All right? So all this can happen. But keep in mind that this is an infection, so your fever will also be there. A fever will be there. You may have a vaginal discharge from here also. So that's what's happening. Okay? These are just pictures of that. Again, what I kind of drew for you, here's the uterus. Here's all that nasty adhesions that occur with the intestines or fallopian tube and whatnot, okay? And you have all these adhesions that happen. Looks like a big spider web. And this is a picture that I took myself when I was working as a doctor. Uterus is up there. There's the fallopian tube. Ovary would be someplace in this area. Maybe that's a part of it. Urinary bladder is up there. Okay, so uterus, fallopian tube, this is just fat, and the ovaries around here. But you have all this adhesions that's over here. There should not be any of this stuff here. The fallopian tube you should identify pretty easily. If you have all this adhesions that's happening over here, and probably a little bit over here too. Okay, so that's what that is. Okay. Leiomyoma. Ooh, a fancy word for fibroid. Okay. Anybody's heard of a fibroid before? Fibroid uterus. Okay. A fibroid or a leiomyoma. Okay. And it really means smooth muscle tumor. Okay. These are benign. That doesn't mean that it's not going to cause any problem. Again, it's benign means it doesn't spread to another organ. Instead, it can grow and grow and grow and compress on things. It could be, well, if this is your uterus over here, okay, here's the uterus. This is multiple lyomas, multiple fibroids. There's some that are found inside the uterus. There's some that are found within the muscle itself of the uterus. Or they could be bulging out. They could be the size of peas. They could be the size of basketballs. okay? But what these things they grow from is a large amount of estrogen. They feed off of estrogen. Estrogen is what keeps them going. You don't see any women who are, let's say, 80 years old who have fibroid uterus. Why? Because they went through menopause and estrogen levels are extremely low. So we don't see that, right? So we see them diminish during menopause. But think about it. In pregnancy, there's going to be a lot of estrogen and progesterone. So they tend to grow more with pregnancy, okay? So large ones can interfere with getting pregnant. Depends on where the fibroids are. It might be so much that if you're pressing against the fallopian tube, it might be something here where sperm is going to have problems getting into where the fallopian tube is because it's being blocked by one of these fibroids. Okay, so it can cause problems with getting pregnant, and the other concern is that there could be problems with the actual labor. When you get pregnant and now you need to push the baby out, you've got to have this contraction of the uterus. Now normally the contraction should go like this, a nice uniform kind of contraction to push that baby out, right? What you need is that 100% right there. You have something like this where there's going to be a big tumor over here. I'm just exaggerating, going up to my chest. But there's a big tumor over here and a small one over here. There's none on this side. And what will happen is this will contract harder than this area. So you're not going to get this kind of unison going on. You're going to get this kind of unison. So you can get 50% here, 50% here. So it's not going to be able to push a baby out in an efficient way. So most women who have a fibroid uterus during their pregnancy, most likely are going to go through a cesarean section, that they can't push the baby out, so they're going to have to make an incision here and get the baby through the abdomen. Okay? So that's what happens with this. Again, they grow massively when you are pregnant because of the estrogen that it feeds off. Okay? So we basically have three different forms of uterus. So let me just draw a picture of a uterus. I don't want to draw the whole diagram. We have the uterus. Okay. Now we can have a subsural tumor, and that would happen outside here. These are the ones that are notorious for pressing on organs or nearby organs. Okay. We can have ones that are going to be intramural, basically within the muscle itself. And that makes the uterus be really huge. Depends on where it is and how big they are. Or we can have submucosal. These are the ones that tend to bleed. Why? Because we're increasing the surface area of the endometrial lining. This is the endometrium. We normally would only have it here and over here, but now we got a lot more endometrial lining over here, so therefore we're going to have a lot more blood coming from this uterus that has a bigger area, surface area of the endometrial lining. So they can cause a lot more bleeding. These don't cause much more bleeding. The submucosal ones do. Does that make sense? The more common ones are going to be here. These are your 70%. These will be the 20%, and believe it or not, these are 10%. The most common presentation for someone with a fibroid uterus is asymptomatic. They just don't have any symptoms. Okay? Most women that are in this classroom may have a uterus that has fibroids on it and not even realize it. Okay? So it's incidental finding. We are going to get symptoms. You're going to get pain because it could be pressing on the organs. Okay? It can cause menorrhagia, more bleeding if you're going to have the submucosal types that are happening over here. It can cause infertility. Like I said, some of them can be blocking the sperm and the egg from meeting up with each other. You can have spontaneous abortion. If you have these submucosal ones, maybe a pregnancy will land on that area over here, but because of the way it's growing, it'll fall out and cause a miscarriage. Okay? And of course, as I mentioned before, if this is going to be bigger up here and there's not much over here, it might not be able to push a baby out should you get, make it to the full term. So you may have abnormal labor in a C-section. Okay? So questions about fibroid uteri? No? Okay. So, we now talk about endometrial hyperplasia. So the endometrial lining becomes cancerous, or it can become cancerous. So again, let me draw this picture. Can't win. Okay. So you have this uterus. And now we have this endometrial lining that should shed off, right? But endometrial hyperplasia is an overgrowth of this epithelial lining. Not, well, epithelial, but it's endometrial lining, okay? This can lead to endometrial carcinoma that's not treated, okay? So what happens here is that this gets thicker because of hyperplasia, right? We learned about hyperplasia, which is going to increase in cell number, not cell size. Well, if it keeps on going like this, it can mutate and become cancerous. That's what we're concerned about with this, okay? So think of an increase of estrogen that causes this, okay? Obesity, very common for women who have endometrial cancer and endometrial hyperplasia. They're usually also very obese. This, what does obesity cause? Why does it cause this? Well, there's an increase of estrogen from testosterone being converted by this hormone called aromatase. There's a lot more aromatase that's in adipose tissue. So if you have more adipose tissue, more fat tissue, there's going to be a lot more aromatase that's going to be secreted. When that gets secreted, we see a lot more conversion of testosterone into estrogen. So therefore, they're going to have a lot of estrogen in their body, and we realize that estrogen causes the endometrial lining to get thicker, okay? So women who may have estrogen replacement therapy for whatever reason, okay? Or if they have anovulatory cycles, in other words, they're not ovulating for whichever reason, okay? Or if there's any kind of tumors of the ovaries that produce a large amount of estrogen. Remember, think estrogen, an increase of estrogen that would cause this, okay? Risk factors, as I mentioned, obesity is the most significant risk factor for endometrial hyperplasia, and therefore it's the most significant risk factor for endometrial carcinoma, or cancer, right? Diabetes and high blood pressure are also risk factors for this, okay? So endometrial carcinoma, okay, postmenopausal vaginal bleeding is cancer until proven otherwise. A woman who's 7 years old should not be bleeding vaginally. If she's bleeding, think cancer until we can actually prove it's not cancer. Does that make sense? Okay. This is the most common invasive malignancy of the female reproductive tract. There's two types of endometrial carcinoma. There's a type 1, where 85% of cases are here. This is due to unopposed estrogen, okay? Meaning without progesterone. It's just solely due to an increased amount of estrogen. Progesterone doesn't have any factor to this. The risk factors, again, is going to be obesity and also anovulatory cycles. Cycles where it's not producing or not secreting an egg. I don't know if that's the proper word, secreting. Ovulating an egg, we'll just say that. Okay. The other one, type 2, is not related to unopposed estrogen or diabetes or hypertension, but it is very, very aggressive. To go from stage 1 to stage 2 or stage 2 to stage 3 happens in a matter of weeks to months. Okay. So that's why the best way to check on this is obviously you do what we call an endometrial biopsy. You put a small tube in here. You can do this right in the doctor's office. It looks like a very narrow straw, almost like one of those coffee stirrers, that kind of thing, but flexible. And you go in and you remove some of this tissue as a biopsy, and they could go under a microscope and take a look at what's going on.